Just trying to plug in stuff.
Okay. I'll start off with an introduction for our speaker. Dr. Anahita Dua MD, MS, MBA is a vascular surgeon at the Massachusetts General Hospital and an associate professor of surgery at the Harvard Medical School. She's also the director of the vascular lab, the co-director of the Peripheral Artery Disease Center and Limb Evaluation and Amputation Program, Associate Director of the Wound Care Center, Director of the Lymphedema Center, and Associate Director of the Vascular Surgery Clerkship, and the Director of Clinical Research for the Division of Vascular Surgery. She completed her vascular surgery fellowship at Stanford University Hospital and her general surgery residency at the Medical College of Wisconsin and her medical school in the United Kingdom. Her lab focuses on anticoagulation and biomarkers that are predictive of thrombosis and hemostasis in patients that have undergone revascularization. She's interested in creation precision point of care medical approaches to anticoagulation for patients post vascularization. She's a part of a technology development team that creates tools to increase walking distance and wound healing while decreasing pain in patients with peripheral vascular disease. Today, she will be giving a talk on using thromboelastography to guide antiplatelet therapy. I'm sorry for the, if I read something wrong, but when I was going through your profile, I was like, okay, it was so great to see your profile there. Thank you so much once again for agreeing to give a talk today. We can start with the talk. Do you want to share your screen?
Sure. Yeah, let me do that.
Yeah.
There we go. You can all see my screen, yes?
Yes.
Wonderful. All right. Well, thank you very much for inviting me. I'm thrilled to be here. And I'm going to be talking to you a little bit about guiding antiplatelet therapy, which right now should sound super boring and mean nothing to you. But by the end of this talk, you're totally going to be like, this is the coolest thing I've ever heard. Okay. So my disclosures are this research is funded by an NIH award that is going to be running out soon. So got a couple R01s under review. And my other disclosures, I really hate amputating people unnecessarily. So let's start out with some background. Basically, in this world today, not just America, but across the world, there is an epidemic. And that epidemic is diabetes. Diabetes is absolutely killing people left and right because there are so many other things that come along with having diabetes, like amputations, blindness, kidney failure, death ultimately. That what's happened is we're seeing patients that are living longer and better because we've got great medical therapies to allow them to live. But what that means is that they're now living with diabetes longer, and we're seeing complications that we never saw before. Diabetes is one of the only diseases that across the globe is increased in every single country by about 10 to 20% by the year 2045. So whether you're a poor country or rich country, no matter what you are, diabetes is taking all of us by storm. Now you might say, well, who cares? Okay, you get diabetes, who cares? Well, if you get diabetes and it results in you not having enough blood flow to your leg, then the chances of you getting a major amputation, which is basically getting your leg cut off above or below the knee, is really high. Now, why do we care about that? We care about that because, as you can see, major amputation at 5 years, a significant proportion of these people are dead. In fact, patients with this disease process die more often than patients with colorectal cancer, breast cancer, and prostate cancer combined. So it's a real problem. And nowadays, because we have a slew of people that are living with this disease process and don't necessarily get the care that they need, and I'll explain that as we move forward, what we're seeing is that more and more patients, especially above the age of 65, are undergoing kind of emergency amputations. And there are about 500 amputations performed in the United States every single day. In fact, by the end of this talk, there are going to be 3 people amputated that currently are, under probably in the pre-op holding area. Now, the reason that we care about amputation is because when you're over the age of 65, 50% of patients that have been amputated will be dead within a year. So it's a big deal, not only for saving the limb, but also saving the life. Now, we've got tons of really amazing vascular surgical procedures that we use to get blood flow to the leg. So why are all these current therapies that we're doing failing? Well, the reason is because we have a tiny, teeny vessel infrastructure of the foot and the lower leg that is very aggressively impacted by diabetes, such that little pieces of calcium are laid down inside the blood vessel and blood cannot get where it needs to go. It's very similar to if there's a car accident on the highway, you're going to see cars backing up and the cops are going to have to detour. In the same way, we have to detour blood around whatever disease process is going on in the leg and get it all the way down to the toes. Now, in a patient with diabetes, there's something called the 200-day rule. What that means is it takes 200 days from when you reestablish blood flow to the wound actually healing. So I go and do this fancy surgery, and it's going to take 200 days of good blood flow for the wound to actually heal. We don't have a lot of great things for below the knee. So when you're above the knee, you can balloon it, which is angioplasty. You can do an arthrectomy, which means you can go in and rotor-rooter, drill. You can put stents in. You can put covered stents in. There are all kinds of things above the knee. When you start to get into this area, we don't have much, as you can see. We basically just have balloons. So it's even more important that if you've gone through opening up a blood vessel, you really do everything to try to keep it open. So the issue is nowadays, there are two primary ways that we can try to get blood flow to the leg. One is putting a stent into the patient's blood vessel. You can see a tightened blood vessel here, stent goes in, and that's the nice blood flow going through. The alternative, which is the old school way that we've all been doing it for years, is if there's a blockage in the blood vessel, we do a bypass around the blockage. Either way, they're pretty cool futuristic things that we're doing, especially with the stents. We've got hundreds of millions of dollars that have gone into technology. But what's interesting is the way we think about this is as if you were parking a $200,000 car in a terrible little house. Because what we do is we spend all this money and all this time getting blood flow for the patient in the operating room. But as soon as they're done with that operation, we go back to medieval times about how we're now going to keep the blood flow going for that 200 days. The issue that's most important is once you get that blood flow going, you need to give patients blood thinners in order to continue to allow that flow to stay for those 200 days. And the rate of thrombosis or clotting of that graft or stent that you put in a patient at this time is 1 in 5 patients by 6 months. So out of 5 people I do a procedure for today, 1 of them is going to come back with a clot in their leg by 6 months. And if you go with the numbers of diabetes and the number of patients that have these disease processes, this is hundreds of thousands of patients that are coming back that ultimately end up getting amputated. And it's a big deal, as I mentioned, because, like I said, the incidence being quite high, it's the leading cause of amputation in patients over the age of 65. And as we talked about, 50% of these patients are going to be dead. So why are we doing all these amazing things to get blood flow and yet unable to keep it open? We have beautiful blood thinners. We have amazing blood thinners. The problem is we can't predict which patients are going to clot, and we have no good way of targeting the blood thinners for these patients to actually keep their leg alive. What do I mean by that? Well, if today I went and ate a box of donuts and then you took my blood sugar, okay, the sugar would be high. And you would say, all right, you need this much insulin to bring your blood sugar down. Now, let's say I have a genetic problem and you check my blood sugar and it's high. Okay, you'd say you still need this much insulin. I don't care whether you ate a box of donuts or you actually just have an intrinsic problem. Either way, this is the treatment. We don't do this same thing for blood thinner. For blood thinner, we say, oh, you had this procedure, you need this blood thinner, which makes no sense because every single person is different. So what our labs strive to do is try to figure out if we can personalize blood thinner for patients in order to objectively give them what they need so that they can keep the actual bypass or stent flowing for the full 200 days. Now, we're not the first people to think about this concept. Idea of kind of ensuring blood thinner is correct has been around for the last 50 years. But you don't have to read all this. But the point is, whether you're looking at the cardiology literature or you're looking at the vascular surgery literature or the interventional radiology literature. Basically, we have no idea what we're doing when it comes to blood thinner. This study, the Voyager study, is the most recent study that's come out about blood thinner. And basically, in this study, what they did is they took patients who are on aspirin only, which is a blood thinner, and compared them to aspirin plus rivaroxaban, which is another blood thinner. And they found, not surprisingly, if you take 2 blood thinners instead of 1, you do better. But what they didn't do is actually include all of the different types of patients that we see on a day-to-day basis that have this disease process. In fact, only 30% of patients that I see on a day-to-day level would have even been eligible for this trial. So it's not generalizable. The other problem is usually if we're going to add a second blood thinner, we add another blood thinner called clopidogrel or Plavix, which is another antiplatelet. It's cheap, it's generic, and we've been tried and tested for years. This other drug, this rivaroxaban that I'm talking about here, costs $400 per month for patients to pay out of pocket. So people just simply can't afford it. Usually people who have these types of disease processes do not have $400 a month to spend on this type of medicine. So the state, even though thousands of patients and thousands of dollars have gone into identifying what the right blood thinner should be for patients, we have still, after 50 years, come up with just give them 1 blood thinner, clopidogrel or aspirin, which is definitely not good enough for all patients. The reason for that is, out of every 4 people, 1 is completely resistant to clopidogrel. So on this call alone, there are probably 2 people that could never take clopidogrel because they'd be resistant to it. So you'll take the pill, nothing will happen to you, but then your blood vessel may clot off and no one will know it's because the drug you were taking isn't working. So we have no way, again, of targeting blood thinners in order to ensure that we're doing the right thing for these patients. Okay? Now, the reason my lab thinks that the problem has happened, why do we have this confusion? What is wrong with this one-size-fits-all concept? Is because it doesn't take into account the extreme variability of different people. Today, if me and Nikita have a lump in our breast and we go to the ER, it would be unconscionable. It would be malpractice for them to send both of us to the operating room and both of us get a mastectomy, our breast taken off. Why? Because we know that cancer markers and tumor markers are different in different people and require different things. Nikita may need chemotherapy and may need just the lump removed. I may need the whole breast removed, but we present the same way, both with a lump in our breast. So this personalizing concept, again, not new. And the idea of the person being the one that really drives their treatment, again, not new. The problem was, and the reason we don't do it for blood thinners, because we have no way of measuring blood thinner in the blood. And we also don't know what's the magic number that's actually the treatment number. If I check your blood glucose, I know somebody figured out normal blood glucose is 100. So if you're above that, you need this much insulin. Somebody figured these things out. But in blood thinner, we have no idea. I can check your blood and say, okay, this is your coagulation profile. I don't know what to do with this information. And that's kind of where we are today. So let's talk a little bit now about clot formation. And I'm not going to get into the nitty gritty of it because it's very complex, but all you really need to know is making clot is like making a pancake, okay? If you come downstairs and I give you a pancake in the morning and it's a horrible pancake, tastes terrible, okay? It could taste terrible and look terrible because I either had 5 cups of flour and no eggs or 25 eggs and 1 cup of flour. Either way, the pancake is bad. So knowing the pieces that went into that recipe is very important to fixing it. Similarly, when you make clot, platelets and thrombin are the 2 things that really form a clot. Platelets clump together to form like a ball, and the thrombin is the glue that holds everything together. So when you take blood thinners, they can either act on the glue or they can act on the platelets. Either way, you need to know what's the problem, because if you don't know, was it the platelets not activating or was it the thrombin not working? Then you can't fix the problem. Somebody's thrombin may be perfectly fine, but then you give them drugs to continue to work on thrombin, but it was the platelets that were the issue. So we need something that can really drill down on a clot and the recipe pieces of a clot to tell you what the actual problem is. And that's where thromboelastography, or TEG, comes into the picture. So TEG, thromboelastography, is basically something called a viscoelastic test. Think of chewing gum. If I were to spit chewing gum in my hand and hold it in my fingers and pull it apart, you can tell how hard or soft the chewing gum is by how far I can stretch it, right? That's basically the same thing we do with a person's blood. We take blood from the patient and we put it on this little thing. It looks like a credit card. It goes inside a machine and we press a button. And then it tells you how quickly the clot is formed, how strong the clot is, and how quickly the clot breaks down, because all clots go through this cycle. And that will tell you what piece of the clot is the problem. Platelets versus thrombin versus whatever. And you can use this for bleeding as well. In fact, while this thing was invented in 1948 to look at clotting, it has been used primarily in bleeding because trauma surgeons figured out, especially when Iraq and Afghanistan happened, that when they have a patient that comes in bleeding like crazy, what should I give the patient? Whole blood? Should I give them platelets? Should I give them plasma? Should I give them, what part of blood does this person need to stop them from dying? And this test can tell you that. So they used it for that. And nowadays, we use it in organ transplant, cardiology, and cardiac transplant, and trauma to guide resuscitation and bleeding. But it has never been used to look at clotting. And that's what we do. So TEG will spit out a graph like this, and it tells you, one, as I said, those little pieces about how strong the clot is, how fast it's formed, et cetera, et cetera. And it also tells you about the platelets, what the actual receptors are doing. Are they working? Are they not? And which receptors are the problem? Because we know what receptors go with different blood thinners. So knowing that we have this objective test, the next step was figuring out what is that magic number that tells me that a person is actually treated, that a person has taken enough blood thinner that they're not going to clot. So what we did in our lab is we took all the patients that underwent some sort of lower leg surgery for vascular, and we took blood from them at 1 month, 3 months, and 6 months. And then we did TEG, and we just followed these patients along for the full year. Of this patient population, always there's going to be a subset of people, and there were about 30, who had clotting of that graft, okay? What we found is, from the day that the person had surgery to the day that they had a clot, about 80 days passed. But what was really fascinating is the thromboelastography blood testing that we did 30 days before they clotted off was predictive that they were going to clot. So remember, we did the checking at 1, 3, and 6 months. So whenever they clotted off, we actually could figure out, okay, what was the last time we did a TEG? Was that predictive that something was going to happen in this person? After we figured out, yes, it's predictive, then we need to quantify it. Well, how predictive? What's the magic number? First thing we found out, which we kind of already know, everybody knows, platelets matter. Platelets, remember we talked about platelets are the clumping and the glue is the platelets being put together? We knew that patients that have more platelets that are activated are more likely to clot. Then we looked to see, is there anything else that can explain differences in clotting? Maybe they're on different medications, maybe they have different surgical procedures, maybe. Turns out nothing. Nothing else is different between these two groups. All the patient factors are the same. The big difference only was the platelets, how many platelets were activated. When you inhibit platelets, they cannot clot. When they're aggravated, they can clot. So inhibition and aggregation are two sides of the same coin. If somebody is 80% aggregating, they're 20% inhibited. What we found when we did a platelet cut point is that for every 1% increase in aggregation, the hazard ratio of experiencing a clotting event went up by 6%, which means a lot of numbers. Platelets matter, and there's a special number at which we can say this person is treated and we don't need to do anything further to them. Okay, so that's that platelet aggregation. What we did was a cut point analysis, and we found that magic number, and that number is basically 30%. If a person's platelets are inhibited to 30%, they essentially are protected from thrombosis. But here's the kicker. Different people need different meds to get to their own 30%. That's the key. So I may just need aspirin and I'll hit 30%. Nikita may need aspirin and Plavix to get there. And some patients need even something more. But the ticket is you have to treat them to that number. Very similar to that glucose thing. Maybe Nikita needs 5 units of insulin to get down to 100, but I need 25. Whatever I need, you need to give me because 100 is the magic number. And that's what we did over here. So we did end up, we published this data in JAHA, which is a decent journal. And then we used this particular thing to start to delve into why different groups of people may be clotting differently. So this one subset, women versus men, very interesting. So women, right, have lower comorbidities than men when it comes to this disease process. Women smoke less, they take their meds better, and they take care of themselves better than men. Yet, women get amputated at a higher number, and their wounds do not heal as fast as men, and no one can explain it. We were thinking all this time that the reason is because women have smaller blood vessels, which really makes no sense because If that were true, then all babies would clot. So what we did is we decided to look using TEG at two groups, women and men, to see what are the platelets doing. Now, as I said, it's a myth that women are healthier in terms of PAD, because in PAD, as I said, they're more likely to get amputated and they're more likely to have their wounds have issues. So what we did is the same kind of analysis. We took a population of people who were women, obviously, looked at their platelet mapping and TEG at 1 month, 3 months, and 6 months, and then compared them to males. This time we used blood samples. So even though we had a certain number, 37 females, 70 males, we used a number of blood samples from them over that time period, so 322. And then we broke them down into groups and we looked at their platelets preoperatively, when they were operated, and after they were operated to see if there's any change. And first of all, as I told you earlier, and as is said in the literature, women have lower traditional risk factors. So this story of them having worse outcomes doesn't make sense. Something else had to be going on. After that, we broke it down again by platelets and surprisingly found that women had higher platelet reactivity than men, whether you look at inhibition or aggregation. But here's the thing. Everyone said, oh, of course, they're women. They have estrogen. Estrogen makes them clot more. That is true. But these are not women who are young. These are postmenopausal women who are coming to see you with PAD. So women in their 60s, 70s, 80s, 90s. But this phenomenon of their platelets requiring more drug to make them shut down persists. What we then saw, again, very interesting. Remember, I told you we broke it down by pre-op, inpatient, post-op. So preoperatively, women and men are basically the same. But then when we operate on them and we give medication, so we've given medication here, right? So now we've done the operation. Now we're going to give you the medicine to keep you stable. Men nicely decrease and get a nice benefit from the medicine, but the women don't. The women stay, even though they're medicated, at the same high level. And post-operatively, again, they stay. What does that mean? It means that women are not being adequately treated, even though they're getting the standard of care medication. So we broke it down by dual antiplatelet and mono antiplatelet, which basically means that either we were giving people 2 drugs for blood thinners or 1 drug for blood thinners, and we checked to see, oh, is that a difference? Maybe that's a difference. Turns out, no. Whether you're looking at 1 drug, 2 drugs, 20 drugs, women are not getting the same therapeutic effect as men. And that is translating to a bad clinical situation, because what's happening is all the black diamonds are clots. And if you look at these women, look where they're all clustered. Aggregation high, clotting off, clot, 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 clot. And if we just took these women and we gave them the right meds, we could push them down to this side and they ideally would not clot. And that is where we are today. So what we did is, once we created a threshold cut point, which was this 30%, we then incorporated it into an algorithm called the TEG-MED algorithm, which I'll show you in a moment, where we iteratively check patients' blood and we treat them accordingly, just like that blood glucose thing I told you. So this is what it looks like. Patients come in, okay, and we give them aspirin or clopidogrel, which are the 2 antiplatelet meds, and then we test their blood with TEG-MED. If they've hit the goal of 29%, we leave them alone and we serially monitor them. If they've not hit the goal, if they're less than 29%, which is usually what the case is, we add another medication. Why? Because this medication is a little bit stronger than clopidogrel, but it's the same drug class. And remember what I told you about clopidogrel? 1 in 4 people is totally resistant. So what we do is we send the patient for resistance testing. Then we check them again 7 days later. Why 7 days? Because that's the life cycle of a platelet, 7 days. So we check them again, and we check them again, and we check them again. And we've got this process so that we can ensure that they stay at 30%. And what is really fascinating about the few patients that we've done so far is that some people at 7 days, they're perfect. But then we check them again in another month, and guess what? They're no longer perfect. Why? Because they've got COVID, or something has happened where they're inflamed, or they took up smoking. So the beauty of this test is that it integrates whatever you're doing to tell me what your coagulation profile is at that time so I can treat it. So whether you're clotting because you smoke 2 packs a day or you're clotting because you have a genetic issue, I don't care. I still want to treat you with the same medications. And so when I know, I can treat you accordingly. And so far, we're aiming for 107 patients, but so far we have done this algorithm on 26 people. And what we found is the standard rate of thrombosis. Remember I told you 1 in 5 people, about 20%. And this is our rate from our Mass General. So these are our patients, which is which aligns with the literature that's published. 20%. Using the algorithm, drops to 3.8%. So it's not perfect. It's like the iPhone 1, but there's something here about targeting people to give them the appropriate antiplatelet medication. We're also looking now subgroup of women and minorities. So I told you women, actually the amputation rate in women is 2 times higher than that of men. The amputation rate intersectionality of Black women is 7.6 times higher. And it's because, again, there's a difference in the platelets and how they're acting. And we've got some preliminary data about that. So overall, the future is bright. We found a way to personalize. Again, not perfect, but definitely the answer for the future. And as we move forward, hopefully will come a day that if I, a 40-year-old woman, get into a car accident and get a surgery, and your grandfather, an 80-year-old man, has the same surgery, we're not both getting the same blood thinners. Thank you very much for your time. I can take any questions.
Thank you very much for the wonderful talk. Really, I enjoyed your talk.
Thank you.
Please go ahead and you can either type your questions in the comments in the chat box, or you can just unmute and ask your questions.
I have a question, if you allow.
Of course, please.
So I'm a little confused with the donut example or the personalization that you referred to. So if I'm not wrong, I said, you said in the context of insulin, regardless of their genetic factors or what they consume, it's the amount of blood sugar level that determines the amount of insulin, right? So that's one size fits all rather, right?
No, one size. So think of it this way. If regardless of what they consume, as you pointed out, they'll have a particular blood sugar, let's say 500, right? And when that person needs to come down to 100, there's like an insulin sliding scale that exists clinically that the nurses implement that will actually continue to give somebody insulin until they hit the 100 number without overdosing it. So it's not a like, okay, if I am at 500 today, you need to give me 8 units and I will get to 100. You might give me 8 units and I might get to 70, or you might give me 8 units and I might stay at 150. So the whole idea that's why we call it a sliding scale, that we can actually change it accordingly. And in that's analogous to this thing, because in TEG, the finger stick that you would use for glucose is basically the TEG, because that can check your blood. And the blood sugar analogy is platelet function. So if your platelets function at 30% inhibition, basically, that's the magic point at which you are treated. But to get to that is different for you, different for me, different for someone else.
Right, but then there's the second example that you used in the same context where you said the blood thinner given depends on what kind of surgery the patient underwent. But that again also sounds like a personalized, doesn't it?
No, because it's the type of surgery. So if you and me both have a stent put in our leg, the stent in our leg currently is what they're that's the standard of care. That's what we're treating. We're saying, if you get a stent in your leg, you need to get this blood thinner and this blood thinner. But the problem is, if you smoke 4 packs of cigarettes a day and I don't, then the stent in your leg is much more threatened than mine.
Right.
So treating the stent in the leg is not good enough. You know what I mean? It has to be who you are as a person determines your ability to clot and what I need to do to stop that from clotting. So we thought historically, and we currently do because we don't have anything better, treatment of the surgery, but you should never treat the surgery. It should always be treatment of the person. And that's why I gave that cancer example. You could make the same argument, she's got a breast lump, I got a breast lump, we both need to have a mastectomy, but that actually makes no sense,
I see. It makes sense. Thank you so much for that.
Of course. Thank you for your question. Somebody wrote something in the chat here. My mom has severe but intermittent pain in her right calf and the front end. Is it related? Yeah, so there's something called intermittent claudication. I'll type it, intermittent claudication. Is your mom a diabetic? You can type and say in there if you want. But basically what that might mean, Yes, yeah. So your mom definitely needs to be checked for intermittent claudication, and to see that she doesn't have any blockages up top, because that might need to have something intervened upon. She also needs something called ABIs and toe pressures, which is basically checking to see how much perfusion there is to the foot. Anybody with diabetes should be checked, screened. Actually, there's a bill in Congress right now that I helped put together that we're fighting for aggressively, called the ARC Act. It's like the Amputation Reduction Act, basically, an Amputation Reduction and Compassion Act, which is trying to get Medicare to pay for these ABI and toe pressures so that we can catch people like your mom, if she has this problem, early before it turns into anything. So she should definitely see a vascular surgeon, because of all the things that can happen. I mean, it could just be buttock pain, it could be musculoskeletal, but absolutely on this list of things could be intermittent claudication and vascular disease. And she should be checked for that to ensure that that's not going on, because that's the most dangerous thing that could happen and can lead to amputation. Anyone else? Yes, I do have research positions in my lab. Actually, as I mentioned, we're putting in funding and stuff right now. So we have a number of postdocs that kind of come in and out. It's very patient facing. It's translational work. So feel free to reach out to me. Right now, it depends on, on what you need and stuff. We do all kinds of things. We're happy to do visas and whatever. Our big thing is funding. So we have 2 R01s that are being reviewed this cycle. And depending on that, we can go from there. No, thank you very much. It's a nice compliment. So yes, love to hear from you guys. I'll actually, here you go, if you ever need anything. So that's my email and this is my cell. Just in general, I actually sit in the weighing building. So if you need anything, let me know.
Any more questions coming up? Okay. Thank you so much for the talk today. Really, it was really insightful. It's just like there were some points where I could relate to, because I have family members who have diabetes, but wasn't sure if they, it's like just like my grandfather. I think he has some problem with his legs, because the last time I saw him, it was like 5 years ago in India. So yeah, so the last time I saw him, his legs kind of became so dark pigmented, and and it also felt like his skin is slightly coming off in some parts of his leg. He's a diabetic from, I think, for the past 40 years he's been a diabetic. So yeah, I could relate to some parts of it, but wasn't sure if, my grandfather really has,
It sounds like he has venous insufficiency. That I can guarantee that, based on what you're describing, that pigmentation is actually hyperpigmentation, because the red blood cells pool in the legs because it takes too long for them to get back to the heart and they break. And when they do, they stain the skin. So that's a common phenomenon. It's almost like a brownish color that comes, and then because it's what happens is it really dries out the skin because blood is hot and it sits there. And that's why they get that peeling. I will say, by the way, I don't know how many, some who's an MD, PhD, that sort of thing, but I am one of the things that's really getting a lot of attention now, and is well understood, at least we know anecdotally, but is like really an issue, is that the South Asian community, so India, Pakistan, Sri Lanka, that whole deal, has a serious issue with cardiovascular disease. We have genetic problems. So it's not the diet, it's not that, it's a genetic issue where there's an increased likelihood of cardiovascular disease, specifically diabetes, heart attack, stroke, and amputation, actually. And when you talk about minorities, because it's well known that minorities have a higher risk of these things, but people are talking about Native Americans, Hispanics, and Black patients, but we're missed. And so now there's a lot of data, specifically looking at the genetics of it.
Mhm.
All of us probably know people where like it's usually a man in his 50s who just dropped dead suddenly. Completely normal guy, not sick.
Yeah.
And it's a different type of disease than an old man who's a smoker who dies in America. It's different. So anyway, I bring it up to say one of the things that we do, I actually run the only homeless clinic that's vascular surgery in the United States here at Mass General, and I run it every couple of months. And now we've started a new organization called DILSE, which stands for Diagnose, Intervene, Live in South Asian Ethnicities. And what we do is we go to temples, mosques, and this and that to everyone's got their shoes off anyway, so to look at patients' feet, and if they're with their kids, we then get them, like your grandfather or like your mom, to see vascular surgeons quickly, so that they don't have to ever get to the point where something bad happens. So if anyone's interested in that too, I think we're doing one in March, one of our first ones at a temple here called Shivyala. So let me know if you guys are interested.
Sure, that would be really helpful. I will definitely pass on the, whatever I learned today to my family and see how it goes with them. But yeah, it was really insightful and helpful actually. And yeah, thank you so much for the talk today. Really enjoyed the talk.
Thank
And
you.
look forward to hearing more about your research. Thank you so much.
Thank you very much for having me.
Thank you everyone for attending the talk. Have a good rest of the week. Thank you.
Bye.